My topic today is about management of gastric gist, and I have nothing to disclose regarding this topic. And before Professor Hamad asked me, I would like to have 6 scenarios here, and hopefully by end of this presentation, we'll be able to have an idea or general approach about these cases. The first case is 1.8 millimeter found incidental. Patient came for GERD, you did endoscopy, you find a lesion, and turned to be GIST. What should you do about it? Another scenario is a 3 centimeter GIST in cardia, also incidental. The third case is 5 centimeter lesion, gastric body presented with hematemesis and upper GI bleeding. The fourth case is 6 centimeter GIST involving G junction with mild dysphagia. The fifth case is 10 centimeter GIST with mets to the liver. And the last case is 3 centimeter with R1 resection with microscopic positive margin. So the first, what is GIST? So in early 80s, the GIST thought to be just a smooth muscle tumor. So until 1998, we got more information about the disease, and it's originated from interstitial cell of Kagel. And around the same year, they found that these tumors actually mutated from CD117 c-KIT, which help us with the tyrosine kinase targeted therapy. If you talk about GIST, the epidemiology of the GIST is quite rare, but it's most common mesangial cell tumor in GI tracts. And if you see all the cases of GIST, more than 50% of the GIST located in the stomach. And actually, I thought most of them asymptomatic, but most of the cases are symptomatic. And most of the symptoms are non-specific symptoms. And in this study, they did not report all the sizes, but the cumulative data, around 50% of the cases, the lesion was more than 5 centimeter. And most of the cases had low to intermediate risk. So the clinical presentation which we see the patients with, most of them are asymptomatic with no specific symptom, dyspepsia, epigastric pain, abdominal pain, early satiety. A symptomatic patient usually found incidental, but keep in mind, those patients can present with upper GI bleeding and also can present with peritonitis and perforation from necrotic tissue and invasion. Knowing GIST is a potentially malignant tumor, so we have to have a risk stratification for those patients and classification. There was many classification in 2002. They classified the NIH classification. They classified the lesions to very low, intermediate, and high risk group based on the size and mitotic activities of the tumor. And they concluded more than 5 centimeter with more than 5 mitotic per 50 high power field carry higher risk features, and any tumor more than 10 centimeters is carry a high risk lesion and probably require adjuvant therapy. Later on, around 2005, 2004, the Armed Forces Institute, they found the non-gastric GIST had a higher risk of recurrence, and they involve non-gastric GIST is a prognostic factor. Around 2008, Johnson and his colleagues, they modified NIH score, and they added actually if the tumor rupture. During surgery or before the surgery, this is another prognostic factor, independent, and they conclude the mitotic figure and non-gastric and rupture GIST are the most important prognostic factors. So if you just take a look to this from NIH, the NIH institutes, the smaller lesion, less than 2 centimeter, regardless of their mitotic figure, they have almost very low to zero risk of metastasis. But just take a look to if the mitotic figure more than 5, and the lesion more than 10 centimeter, they probably have metastasis up to 86%. So there is element you have to know when you assess patient with GIST, which is the molecular subtypes. Most of them, 75%, they have KIT positive, and also the platelet-derived growth factor receptor alpha. But remember, there is a wild type of GIST that does not respond to the regular therapy. Remember, there is three type histological type: the spindle cell, the epithelioid, and the mixed type. Most of them are spindle form. And if you think about the genotype, if the KIT mutated, there is many exons, and exon 9 does not respond to the tyrosine kinase inhibitor. So you have to choose different therapy. It's also associated with neurofibromatosis 1 and other inherited disorders. And remember, keep in mind, when you do endoscopy, find incidental lesions, there is other mimicus, which was already discussed in details. But from my experience, usually when we take FNA, FMB, they report it as spindle cell tumor, spindle cell muscle. So what does that mean? It doesn't mean anything. So you need immunohistostatin. And immunohistostatin, you have to have the KIT positive for GIST, and also you have to see the other, the S100, which is for schwannoma, and also the CD34. So you find a lesion which you think it's resectable. First, if it's symptomatic, so we have no discussion, so it has to be resected. But for patients who has asymptomatic, then you have to check the size and have thorough assessment using the endoscopy ultrasound to decide for malignant features. So even if it's less than 2 centimeters, you have to look for the malignant features, including ulceration, irregular margin, inhomogeneous appearance, necrosis, cystic changes, foci. This is very important to decide for resection. So I think this was discussed, but any submucosal lesion more than 2 centimeters has to be biopsy and decide if this is GIST or not. We care about GIST, and probably we care about others for the patient's sake, but because of the malignant potentials of the GIST, and the risk of metastasis increase when it gets more than 2. And they think EUS biopsy, FNA, FMB is the way to go. And for smaller lesion, less than 20 millimeters, 2 centimeters and less, regardless of mitotic figure. And remember, mitotic figure, the FMB does not tell you the exact mitotic figure because you're taken from focus. And the actual histological, the actual biopsy is the one is going to tell you. So in the presence of resection, you decide for resection. This is from European guideline. They think 3.5 centimeter, less than 3.5 centimeter, you can offer them endoscopic therapy. Which was discussed as well, and we'll discuss in a brief. Another guideline from 2022, the AGA guideline, they recommend after EUS assessment, muscularis propria lesion has to be sampled because you want to make sure whether this is GIST or not. And less than 2 centimeters has low rate for metastasis regardless of the mitotic index, and less than 2 centimeters you need surveillance, or you can also remove it with the advancement we have in the endoscopy. Optimal surveillance, less than 2 centimeters without higher risk feature, we don't know, but usually we do it yearly. The standard, when we go with the standard, is surgery. So you have a lesion, you have GIST, malignant potential, you go with surgery. And it depends on the location.
2 minutes. 2 minutes.
2 minutes? Okay. So you decide for surgery, and it depends on where is the lesion. You decide how do you remove it. And the other procedure which was discussed by Dr. Shaima is the endoscopic tunneling procedures, and you can remove it easily. based on the size and also the location, also the full thickness that was discussed. There's a comparison, meta-analysis of 12 studies comparing the laparoscopic wedge resection versus FTR, and they found they have similar complication, hospitalization, recurrence rate with similar 5 years free survival. It's very important to decide for the molecular subtype, to check molecular subtype, because the kit usually respond well to imatinib as a first line, but if there's a mutant in platelet-derived growth factor alpha, they usually ivartinib is the way to go, and succinate dehydrogenase also is a different category, wild type, and may require a clinical trial. The guideline from the ISMO, basically, you want to check if it's responsive to imatinib. If you are sure R0 resection with no higher risk feature, you can go by removing the lesion and follow them up later, surveillance. But if they have higher risk feature, you have to overcome therapy for 36 months. If they have higher risk features or unfavorable location, you have to over them preoperative therapy to reduce the size, and then you over them surgery. This is for the advanced metastatic GIST. It has a very complex form, and the other options left with us, especially with wild type immunotherapy. And as you see, there's lots of randomized controlled trials, some of them terminated, completed, still recruiting on the way for checkpoint inhibitors, immunotherapy, cytokines, and it has promising data. Another way to ablate the lesion is AUS guide that was published in GIE in 2003 for GIST, and was injected with ethanol 90%, and there was a reduction in size and scarred the lesion after 6 months. This is my last slide, but just 1 minute. So for Dr. Hamad, for 1.8 asymptomatic patients, an antrum, no symptoms. So probably this lesion, you have to have a multidisciplinary team. It's low risk of metastasis, you can surveillance them. For 3 centimeter, then the size is bigger, the risk of metastasis is higher, so probably you need to remove them, and you have 2 options, the endoscopic or the surgery, and the facility available. 5 centimeter with GI bleeding, this is out of the option, so you need surgery for that. If it's involved GE junction with mild dysphagia, and you have to decide multidisciplinary team, you may over them therapy first until you reduce the size, and then you remove it. For Mets liver, this is for advanced. You have to get mitotic. You have to get the what is the molecular type, and then you decide for adjuvant therapy. And for R1 resection, you go with adjuvant therapy and follow up. So GIST is a rare neoplasm. It's mostly actually non-specific symptoms identified by image or endoscopy CD positive. Risk stratification based on the tumor size, mitotic location, and perforation, and the approach as discussed. Thank you.